And one of the things that I always talk to with my patients and the families is note that we don't call a glioblastoma GBM a stage tumor. We call it a grade because it likes the brain and any central nervous system tissue. So when we think of it that way and we think about the years of research that have gone into finding these things. So for Dr. Andrews, it's been, almost 20 years of work.
Yeah.
And other scientists, a lot of work.
It doesn't happen overnight.
No, and it's the results of that we're seeing now. And so to challenge the tumor in every kind of biological mechanism possible is what trials are about. It's the science that a scientist does at a bench that comes to fruition many, many years later.
Yeah.
So, we need to sort of remember that we always need to bring hope to our patients and perhaps one day find something where we can make GBM a chronic disease like many other diseases. So that is a hope. One would always like to have the gold standard of a cure, but if we can't get cure, can we make it chronic? And that's something that we can control.
Welcome, everybody, to a brand new season of the Game on Glio podcast. We are in season 5 of Game on Glio. I can't believe how far we've come and where we are in this journey right now. We are 5 seasons in, and we are kicking off. We always kick off at the start of Brain Cancer Awareness Month. But this season, I want to do something a little different. Every season, we seem to have a theme. We have some amazing guests on. But this season, I want to do something a little different. Obviously, we're going to be doing more video episodes, and we have a great little setup, which I love. We have some amazing guests that we're going to have on the show this season, but I also want to bring in a lot of hope into this season. I've been reflecting a lot on my own journey and kind of where I am right now, 4.5 years out from Mike's death. So much has changed, and yet so much hasn't. And I've been struggling a little bit with putting my trust and my faith in things actually working out. I found this really great quote from this book, Lisa Turkhurst, I think is her name, for all those who want to see. It's called I Want to Trust You, But I Don't. Now, yes, this book is based a bit in faith, and I've always said on this show, it doesn't matter what your faith background is or if you are faithful or not. It doesn't matter what type of faith you are, what religion you are. I do try to talk about it once in a while because I am a person of faith. However, I have struggled with my faith. And in this book, there's this great quote that says, I have more faith in my fears coming true than in God coming through for me. And that hit me hard for a couple of different reasons. One, because I think that is our tendency. Our tendency is to, when really bad things have happened or traumas have happened in our lives or really bad diagnoses have happened in our lives, we have a tendency to put more faith in our fears because now some of our fears have been realized than in the things that we can't see and the hope that things will work out for us. And that has sat with me a little bit because as I enter this new season, this new phase of my life, I'm also meeting so many more cancer families, so many more brain cancer families, and a lot of other different cancer patients as I go along. And sometimes it has me questioning and it has me wondering why? Why does this continue to happen? Why are we struggling so much with these diagnoses happening in individuals that are young like me? It's a question that I'm going to try to really work through as we go through this season. But what I'm also starting to realize is that I want to have faith. I want to have faith. I want to have hope in good things still ahead for me, still ahead for all of us. I want to have faith in goodness, in light. I want to find joy. I want to find happiness. And that's what I want for all of you. It's hard sometimes to talk about these topics. It's hard to be in it. And for those of us that work in this space, it's hard for us sometimes to see others suffering, especially when we know what that suffering feels like and looks like. But what I will say as we go into this season, I am bringing on some guests that are not only extremely hopeful and very powerful, but show us what it means to actually get to the other side, to be resilient, to see the light, to know that there really are good things that can come up. And so that's what we have ahead for us this season. We have stories of second chance love. We have stories of cancer survivors that are 15 years out. We have stories of widows and widowers that have gone on to find love again and have found a way forward. We have some inspiring stories. We have some amazing doctors on that are talking about innovative new treatments in the brain cancer space and what it means to be a woman talking about healthcare, talking about health as a women's advocate. And that's extremely important as well. So I hope you'll join me. I am so looking forward to this season. I am so looking forward to having all of you on. Share us a note, send a note to us, talk to us, let us know what you're feeling, let us know what you're thinking. As we go through this season, it's always about communication. It's always about sharing stories with all of you. It's important to me. This work is vitally important to me, to my staff, to everything that we do. The stories that we tell are supposed to be uplifting and hopeful all of the time. And there will be times where I will be sharing moments where I am struggling. And I've definitely had those moments. Doesn't matter how far out you get, you still have a tendency to have those ups and downs. And there are some new challenges that I am facing that I will talk about as we go through the season. However, for the most part, things are going extremely well. And so as we begin the new season and as we get ready to start episode 1, I have two amazing, wonderful doctors that are going to be joining me next from UNC Health. They are shakers and movers and innovators in the brain cancer space. And I am so grateful to have them on as we talk about the challenges of navigating second opinions, innovation, clinical trials, the work that they're doing, how to combat and navigate through health insurance companies across state lines. We're going to be talking about all of that. It is an amazing, wonderful episode. So glad to have you all with me. Join us as we sit down with them next after a brief word from one of our premier sponsors.
This season of the Game On Glio podcast is sponsored by GT MedTech and GammaTile Therapy. Learn more at GammaTile.com. This season is also sponsored by Imvax, personalized, full tumor-derived immunotherapy. Learn more at Imvax.com. This episode is sponsored by Plus Therapeutics, power and precision in radiotherapeutics. Learn more at respect-trials.com and radiotherapeutics.com.
Welcome, everybody, to another season of the Game On Glio podcast. We are in season 5 of this show. I am so grateful to be able to continue doing this show with all of you listening and all of you followers. You help make this show what it is for us. You help allow us to do what we do. We have over 50 episodes that we have produced to date, and we are still in the top 10% globally of all podcasts. That's 3 million podcasts that are aired, and we're in the top 10%. So we know that the work we do is important. It's vital. So thank you guys so much for joining us. We are kicking off our new season 5, in May. Here we are, beginning of summer. We're grateful to be here, but it's also an important time of year. It is Brain Cancer Awareness Month. So many of us that do fundraising and have foundations do a ton of work during this time of year. We also have a lot of doctors, neuro-oncologists, neurosurgeons that are in the fight with us. 2 of them are here with us today, and they are an important, integral part of the work that we do. And I couldn't have had 2 better people to kick off our season with than these 2 individuals right here. So let me welcome them. We have Dr. Soma Sengupta. who is an MD, PhD, MBA, and a whole lot of other titles. She is a board-certified neurologist, a fellowship-trained subspecialty board-certified neuro-oncologist, and is fellowship-trained in integrative medicine, which I can't stress enough is just so vital. She's a physician scientist, clinical trialist specializing in brain tumor treatment and research with over 90 publications on clinical trials, case reports, lab based research, and healthcare policy. She received diverse training that included immunology research at the Cambridge Institute of Medical Research at Johns Hopkins and pediatric brain tumor research at Boston Children's Hospital. All these experiences focused on how a cell senses and communicates with the outside world through the transport of ions and metabolites. Dr. Sengupta's primary area of research looks to improve patient outcomes for brain tumor patients. This includes individuals with brain tumors, primary brain tumors, as well as metastatic brain tumors. Dr. Sengupta is a recipient of the Leonard Tao Humanism in Medicine Award, presented by the Arnold P. Gold Foundation, and the Unsung Hero Award, presented by Cancer Family Care. So, Dr. Sengupta, thank you so much for being with us today. Alongside of her is her colleague at UNC, Dr. Dominique Higgins, who is an assistant professor of neurosurgery specializing in neurosurgical oncology and brain tumors. He earned his MD PhD at the Mayo Clinic, focusing his research on glioblastoma stem cells. He completed neurosurgery residency at Columbia University and a brain tumor fellowship at the University of Miami. His research centers on malignant brain tumors, including glioblastoma. Dr. Higgins has received the UNC School of Medicine DEI grant, the AAN Minority Scholars Fellowship, and the Mayo Medical Scientist Training Program BOMER, I think that is, scholarship. So it's a mouthful to read for both of you guys. Thank you so much for being with us. The work that you guys do is vital, and I am just so thrilled to have you both here.
Thanks for having us.
Thank you very much for having us.
So I want to start, we might as well start with, so the work you guys do is both in neuro-oncology, neurosurgery. It is a intense field. It is a heavy field. So why neurosurgery? Why neuro-oncology? What made you guys decide that this is the area that you guys wanted to go into for your professional careers?
So in my case, I focus more on the neuro-oncology side. And the reason for that is, as a child, one of my friends going through middle school had a DIPG, as it was known back then.
Oh, wow.
And, I watched her sort of fade away. And one of the things she made me promise, she said, "You'd better do something to save people like me someday." And I promised her that I would do something. Okay. So I didn't know what that entailed. I was in school. Most kids don't, right?
Yeah.
And so, sort of fast forward, I trained at Cambridge. I started off doing a neurosurgery training program, actually, and then developed autoimmune disease, and which affected my hands predominantly. Then shifted and went into neurology, but maintained my research interests. And I was very fortunate at Cambridge to be able to work in various areas in immunology, membrane proteins, and I loved it. And I knew that's what I wanted to do. And then when I moved to the United States, due to sort of family reasons, I was based in the Harvard system, and I decided to do a neuro-oncology fellowship, coming back sort of full circle to sort of the promise I made as a child to a friend. And along the way, a family member and a very close friend of mine, a fellow neuro-oncologist, both succumbed to brain metastasis from breast cancer. So for me, it's not just about being a neuro-oncologist. For me, it's keeping a word to somebody that I made a long time ago.
Trying really hard not to get choked up hearing that. Dr. Higgins, what about you?
Yeah, that's very touching, Soma. My journey here is a little bit different. I had an interest in neurosurgery just because of the challenge of the profession, and I wanted to be a doctor. I like working with my hands, and I thought what's the hardest thing I could do, and it was neurosurgery. So I started shadowing back when I was in high school, and when I was in college at Stanford. I worked in the lab with Irv Weissman, who discovered cancer stem cells, and
Yep.
Sam Cheshire, and they were working on glioblastoma. So that was my introduction to it, and I was fascinated about the disease. It is so aggressive and affected patients so quickly, and these families had such a swift life change that I just wanted to continue learning more about it and seeing if there's something that I could do to contribute to the science and the medicine to try to make a dent in it. So when I went to medical school and did the MD PhD, I kept working on it and been doing that since.
Wow. Well, I am grateful to both of you for doing the work that you do. But let's start off, Dr. Higgins, I want to start off with you. As we move into more advancements in neurosurgery, what are you seeing in advancements in the neurosurgical field? And with the burgeoning of AI and that structure, is that helping or hindering the advancements in neurosurgery?
I think it's definitely helping. From a technologic standpoint, we've gotten better and better at taking out brain tumors. So we have a lot of technology that we use in the operating room. We can use navigation and essentially create a GPS for the brain. We
Mhm.
can label the tumor cells with the different colors so we can see them under the microscope as we're taking them out to protect the nerves. We can do surgery with the patient awake and test function and do specialized mapping to make sure that the function is great. And so we've gotten really good at taking out as much as we can safely. And that's something I think we've been proud of as a field and our ability to advance that. But I think, obviously we haven't gotten to the end goal where we can, cure this disease or at least provide a significant extension. And I think that's the combination of where the surgery and the medicine and the research work together, and AI is definitely at the forefront of that. Is in every field these days.
Yeah.
One of the ways we're using it, we create specialized maps of where all the nerves are running in the brain that's individualized to that patient, and so we can use that what we call tractography to
Okay.
kind of map out where not just the nerves that control movement and speech are, but things that we think that could affect your personality or your cognitive function, where those things lie, so we can have a better sense of how we can do the surgery more safely. And then as we get more molecular data, how to process all this information and make sense of it. That's another area where AI is coming into play to identify trends that we may not be able to see otherwise, or at least pick it up faster. So I think it's definitely helping.
So let me start with that last piece. Trends that you're seeing, that having the AI to help with that, how crucial is that? Can you give an example as to how that can help in doing a brain surgery and potentially help the patient down the road?
Yeah. So one of the ways that folks are trying to use this to directly impact surgery is to look at the tissue as we're doing it during the surgery to say, can we get a sense of is how aggressive this tumor is just from a not traditional processing of the tissue sample in the OR, but a rapid AI based software to say, we can, with high degree of certainty, say what this tumor is, how likely you are to be beneficial from an aggressive resection, and then can directly guide our decisions in the OR. And then also when the after we leave the room, and Dr. Sengupta is looking at a list of mutations and changes in the tumor, what drug do we use to treat this with? What are the possible combinations that we could do? So that's another avenue that's not yet being implemented, but is on the forefront, I would say.
And that's gonna be a huge, huge, huge piece,
Yes.
in helping patients down the road. My last question before moving to the next piece is, in using AI to map out and structure the brain and doing the brain surgery, how crucial is it to get as much of the tumor, if not 100% of the tumor as possible? What does that do for the patient when you're able to really precisely get as much as possible, if not the whole thing, for their longevity, for their treatment process?
Yeah, this is the age old debate is how aggressive should we be, and study after study has pretty conclusively said that, the more you're able to take out, the better the patient does. And so we try to, in each patient, get a complete resection of, where we see that the tumor is. But we also have to balance that. We call that the oncofunctional balance. So if we take out all of the tumor, but the patient has some kind of deficit or weakness after the surgery, then we know that that may offset the benefit of taking the tumor out. So it's an individualized decision. We try to take out as much as we can safely, and so we always shoot for a maximal safe resection. And that balance is where we think the patients do best.
Perfect. And I'm picturing, I mean, it's such an intense thing for this is you paint a really good picture as to the amount of skill, precision, creativity, ingenuity, and also stress that a surgeon feels walking into this room and having to deal with, okay, there's a million different things we have to assess right here, right now, as we try to get this tumor out. Dr. Sengupta, as this all evolves, I mean, there's been a burgeoning, just a reckoning, it seems like, in the last 5, 6 years to really move the needle when it comes to aggressive brain cancers like glioblastoma. And we've had a lot of biotech companies and industries really jumping into the forefront of how can we better serve the patient? How can we better help them? One of those companies is Imvax, who developed a clinical trial that just ended their phase 2B, the IGV-001. And you guys recently became a PI for that trial at UNC. Why did you feel it was important to participate with IGV?
That is a multi-layered question. So, as Dr. Higgins already said about his career journey and how he got interested in research, if we think of another neurosurgeon, Dr. David Andrews, who developed the technology, I mean, he will tell you how many years he spent doing the research and running the phase 1 trial and that data as well. And looking at that data, I became committed to the idea of running the phase 2 trial. So I made contact. I was discussing the trial with the group and really got to know them as a partnership. And what also, remembering my past, which is being a patient advocate by having been on the journey in a way myself through friends and family, I decided that I wanted to work with a company that really had the heart of the patient. So it wasn't all about just pushing a bottom line. And Dr. Andrews, because he has been a practicing brain tumor neurosurgeon, he has been a researcher. This technology came from the lab. And then the chief science officer, Mark Exley, who I actually knew from a very long time ago from Beth Israel Deaconess.
Yep.
And I knew of his phenomenal immunology research in the area of NK cell technology and other immune cell technologies. And I do have a background in immunology. So I decided that this was something that would be great to have in our arsenal of trials.
But can you explain to our watchers and our listeners a little bit about how this trial works? Because it is fairly unique in the sense that there's almost a double surgery that takes place because it's the brain surgery, but then it's taking some of these cells, correct, from the glioblastoma tumor, and it's implanting them into a petri dish, I believe. And then there's a little device, I think it's Goldspire is their device, and that's actually implanted back into the abdomen. So, can you, one of you, just explain a little bit about the importance of why it's done this way and how, I mean, this is innovative. This is very innovative in how to train the body to attack this.
Yeah, happy to. It is very complicated, and I think one of the things when you explain it to a patient and say these are the steps that you're going to go through, it's important to be able to describe it in a way that everyone can understand what the journey looks like. And It's a
Surface level. Very surface level.
definitely outside the box, but it's been such a tough disease that I think we need something that's innovative, that is
Yes.
outside the box to make a dent in it. So essentially, the first step of the surgery is to take the tumor out, like we normally do, and that ends. And so the big picture goal is to essentially create a personalized um, vaccine using your own tumor against it. And so you send the tumor to Imvax, and then they process it and they load it with this oligonucleotide, a string of nucleotides that stimulates the immune cell the immune cells in your body when it gets reimplanted.
Mhm.
But to contain the tumor, they put it in this chamber so that the tumor cells don't leak out, and then they radiate the tumor cells so they're dead, so there's no chance that they can grow in another part of your body. So it's tumor cells embedded in this cage that they can't leak out, but the little antigens, the proteins that tell the immune cells that this is something bad, can leak out and stimulate those immune cells. So about 3 days after the tumor is out, we implant those chambers in the abdomen, because near your abdomen you have essentially a hub of immune cells that can be primed to attack something. And so those stay in for 2 days, and then after that, we just take those out, and then you go on to regular treatment, as you would if you didn't have the implant. But during that time where the chambers are implanted, you're essentially priming your immune system against whatever proteins or markers the tumor expresses on your particular tumor. So I think that's what's pretty cool about it.
So, Dr. Sengupta, especially because of your work in immunology, this seems really important because we all know that one of the biggest barriers, whether it's DIPG, whether it's glioblastoma, whether it's another form of aggressive glioma that eventually leads to glioblastoma, it's it's a matter of getting through that blood-brain barrier, which is meant to protect us as we grow up. And sometimes something like this happens, and then it becomes a hindrance because breaking through that barrier can be so tough. So having something like IGV-001, being able to train the body and our immune system on which cells need to be attacked and which cells don't, how vital is that? How important is that in this phase of a trial like this?
So I would say that it is very important because teaching and training your immune system to do the correct thing. And as we learn more about the immune system, we understand that the brain itself has a tumor microenvironment, and it's not just the blood-brain barrier, but how do immune cells crosstalk to one another.
Mhm.
So I think this technology, as Dr. Higgins mentioned, is highly innovative for that reason, because you're teaching the immune environment to attack an invader. And normally that invader would not be recognized because it's growing inside the system. So it's basically changing the hardwiring, if you like.
Which we all know is extremely important. And I do a lot of work with Imvax regularly. I know the team over there. I know how passionate they are about finding some better options for brain cancer patients. So I am thrilled that you guys are on board with this. As you guys have gotten into the trial, and I know that we're still waiting on data to be released from them. The goal, and the fingers are crossed, my toes are crossed, everything is crossed that everything looks good and we can move into a phase 3 with IGV. What has your experience been like in working with this trial as far as the surgery goes, dealing with the patients? How open have patients been to a trial like this?
Discussing a trial like this with patients, they're initially very excited because they like the idea of a very novel technology and in a type of, they like to think of it as a vaccine approach. It's more than just that. It's actually retraining and rewiring your immune system to attack a tumor. So I think that many patients, when they listen to it, are on board. But on the surgical side, I will let Dr. Higgins weigh in.
Yeah, I think the patients have been, agree that they're excited about the idea of trying to do something upfront. And I think that's what was impressive about the trial. It was for newly diagnosed patients with glioblastoma, and the idea of being proactive, saying that we're just going to do something that's different that we know is promising, to try to get the best results out of the gate. And I think that's what really motivated a lot of the patients, despite having to do the additional surgery, which um, what was well, I would say well tolerated, from
Mhm.
the feedback I got from them, but it's still a two extra steps in the procedure. But I think that the idea of combating this upfront was what was motivating.
So, feel free, either one of you, to answer this question. But why do you feel that it's so important to have clinical trials like this continue, whether it is IGV-001 through Imvax or Sonobird through Carthera? There are so many advances in the way we're trying to approach aggressive brain cancer. Why is it so important to think outside the box and to come up with clinical trials that are innovative like this?
So I'll take the first part of it and also defer then to
We have
Higgins.
a good rhythm going.
So basically, if you think of a chameleon, so your GBM is a chameleon lurking there and changing with the surroundings, with
Mm,
its microenvironment, with the way the blood-brain barrier operates, with the way that the blood vessels operate.
mm,
So just that alone, you can see that there are various ways that our basic and translational scientists
mhm,
have done research for so many years to understand the biology of these tumors, which is so intricate and complex. And they're very different to tumors in the rest of our body. And one of the things that I always talk to with my patients and the families is note that we don't call a glioblastoma GBM a stage tumor. We call it a grade because it likes the brain and any central nervous system tissue. So when we think of it that way and we think about the years of research that have gone into finding these things. So for Dr. Andrews, it's been, almost 20 years of work.
yeah.
And other scientists, a lot of work. You know,
It doesn't happen overnight.
no, and it's the results of that we're seeing now. And so to challenge the tumor in every kind of biological mechanism possible
Mhm,
is what trials are about. It's the it's the science that a scientist does at a bench that comes to fruition many, many years later. And many discoveries will never get to the patient because they enter what's called the valley of death because they don't get funded.
yeah.
So, we need to sort of remember that we always need to bring hope to our patients and perhaps one day find something where we can make GBM a chronic disease like many other diseases. So that is a hope. One would always like to have the gold standard of a cure, but
Yeah.
if we can't get cure, can we make it chronic? And that's something that we can control.
Yeah, I think I would echo what Dr. Sengupta said. I think one of the other important things is that um, we know what the end result looks like
Mhm.
with our standard treatment, and it provides a lot of benefit, but we want more, and I think that's what clinical trials have the opportunity to give to our patients. And I think sometimes there's a stigma around it, that if you're in the not getting the experimental group, you're in the control group, and we've moved away from doing placebos, like, so everyone gets treated,
Right.
but is whether or not the new treatment is as good or better as what we're doing right now. And so I think everyone benefits, but in that too, we get new answers as to what the future should look like.
I think this is what you guys are both touching on is extremely important, and it kind of dances around the topic of funding. And, it's one of those things where it's been challenging to get funding at times because people hear investors, grants, wherever the money is coming from, people hear the word brain cancer and they think, oh my God, it's a lost cause. Well, it doesn't need to be a lost cause. And that's the hope that I would want everybody to remember is brain cancer or breast cancer started out as a lost cause, millions and millions of people being diagnosed. And it took a while to figure out we actually have a way to cure this. We have a way to treat this. There was better technology, better treatments. But every cancer has started out somewhere where it was a cancer that nobody had seen before. And then you had to figure out the best ways to get at it. And, Dr. Sengupta, exactly like you said, I'm not I know that we are probably a long way off from a cure, and some people may not wanna hear that, but I would be ecstatic. I mean, I would be putting confetti cannons out in the yard if we could get to a place where brain cancers like glioblastoma could be treated chronically like rheumatoid arthritis, where you have a flare up, you figure out the best course of action, you bring it back down, and the patient gets 10 years, 15 years, 20 years, maybe 30 years or more, where it may be chronic. We have to figure out the best way to treat this, without hindering their cognitive capabilities or their quality of life. But how exciting would that be? And it's a reminder too that all of the clinical trials where we are seeing the evidence and we are seeing the hope in it right now has been years in the making. And I think that it's vital that you guys have touched on that because, for me, I'm seeing the surge of all that's coming because of all of that work. But it's such a great reminder that this has been 20, 30 years in the making for a lot of these neuro-oncologists and neurosurgeons that have been doing the legwork this whole time just to get to this point.
Yeah, no, that's spot on, and funding obviously is a very topical issue, and I think
Hmm.
it's been amazing to see the different cancer communities, like the ACR and the ACS, and their efforts of in terms of maintaining that emphasis on the fight to
Hmm.
maintain research and funding and clinical trials, and to really support our patients that
Hmm.
are depending on the work that we're doing. At UNC here at Lineberg in the Cancer Center, we've seen some amazing things with CAR-T and some of the work that we're doing here, in addition to the trials that Dr. Sengupta and I have been able to lead that are kind of the multi center studies as well. So the first thing I tell my patients is, hope goes a long way, and so and we try to maintain that.
So, Dr. Sengupta, this kind of piggybacks on what Dr. Higgins was just talking about and centering around what we've been talking about a little bit. Eh, Do you feel it's important for neuro-oncology departments to really collaborate and work more together? There seems to be this struggle at times, this dichotomy across departments nationally about playing nice in the sandbox at times. And, when it comes to collaborating, it's really central, to be able to for not only for collaboration and innovation, but for patient health and patient care. How important is it for us to learn to be able to work a little bit better across departments nationally?
So, you touch on something that is very important. I think, a lot of these discoveries from the basic translational scientists, um, a lot of them came about through collaboration. It is not, if we start working in silos,
Hmm.
we have to remember that it's not about us. It's not about our egos. It's about the patients and their families.
Yeah.
The minute you can get past that it's all about me, and the all about me can occur um, within your institution. It doesn't have to be in different institutions, or it can be different institutions.
Hmm.
um, it isn't all about anyone. It's all about those patients and the families. And I think at UNC, we've worked together with Wake Forest, Duke, ECU, and we had our first combined brain tumor symposium, which was very exciting for us
That is.
to discuss research and think of ways of collaborating with one another. And, we, as neuro-oncologists, and I'm sure Dr. Higgins will say the same in neurosurgery, we have our speed dial colleagues that we contact because, if I don't have something for my patients, I would want them to go somewhere else if they're financially able. If they're not financially able, then to find options that they can have that are sort of financially viable and also time viable, because some of our patients have young families. So to be respectful of their journey and also to say, I don't know. Why don't you reach out to so and so? They might have an answer for you. We can't know it all, and we can't have the answers to our hands. And even with websites, you alluded to the sort of AI era.
Mm-hmm.
With large language models, with generative AI technology, um, companies like XCures and others are building, platforms where we can sift through trials more rapidly and, garner the mutation and match it to a trial. And, brain cancer is more than just the mutations. It's so many other things.
Mm-hmm.
Um, Things like metabolism, which Dr. Higgins studies in his lab. Things like how does the brain tumor maintain the electrical activity and cross communicate. I study that area in the lab, but very well known researcher in the field is my colleague Dr. Michelle Mongi. So I think we have to remember that there are so many people that are doing it, and we all do it, with the hope of changing that needle. And wouldn't it be much faster if we work together?
I think you touch on a couple of things that I think are really important to stress. It's almost like finding that tether, among all of us. There's one basic goal. And if we could get neurosurgeons and neuro-oncologists and research teams to remember that one tether that everybody has, it would be very beneficial. And I've seen, I do a lot of patient advocacy, and I have seen at different brain cancer centers where they favor one trial over others. And so they will only mention one or two trials to a patient and family because they are partnered with that facility or that center. And instead of giving a patient and their family a full rounded picture of here's everything that's available, here's who we partner with and the trials that we can offer you, but here is everything else that's going on, and helping them advocate for themselves on their best options available. I've seen a lot of centers miss out on that and not do that. And then I get calls from patients and families that say, this is what we were told. Is there anything else? And then when I mention other trials going on or other centers and some of the innovative work they're doing, they're like, well, why weren't we told this? So, I have seen that. And, I want to throw this question to you because I came across this recently with a very good friend who we're not sure if it's a recurrence yet or not. And they have to monitor. There's some symptoms that came up. They're a 6-year survivor, by the way, which I am very happy about. But they were looking at, okay, can we get some other opinions nationally? Because there's a discrepancy between the PET scan and the MRI scan. And so what's going on? And can we get some clarification so we can make the best decision for our family? Because they're young, they're only in their 30s, as to, okay, what do we need to do next? Do we need to go to another facility? And they were having a lot of trouble because their insurance company was pushing back, and there was pushback with the department they were working with on, no, you can't go and get this opinion from this facility. It's in a different state. You can't be working with somebody from a different state. And they're like, why why is this so hard for us? I'm just trying to survive. I'm just trying to make sure that I'm staying on top of things because I'm 6 years in and I have 2 kids under the age of 5. And so, what are your thoughts around that? I mean, is it a barrier with insurance companies? I mean, is that kind of what we're seeing with some of this cross-state stuff when it comes to patients getting opinions?
It's more than the insurance companies, actually. It's also the state health line telehealth opportunities.
Oh.
So, since the pandemic, we can only do telehealth within our state unless we have licenses for other states. So, medical licenses are such that they only operate within the state. And so the clinician has to get a license for every state. And you can imagine the cost of that.
Oh, there's always a barrier. There's always a barrier.
So it's a practicality thing. And then how do you cover things medico-legally? So if we use, examples of a very topical area like cannabis,
Mhm.
okay? Cannabis is legal in some states and not in others,
Mm.
right?
Yep.
Similarly, we really don't have a uniformity of approach.
Mhm.
So patients can't really easily get access. And then as clinicians, if we start giving free pro bono advice,
Mhm.
our medical legal practice doesn't cover us. Okay.
Interesting.
Yeah.
Okay.
So medical legally, if something happens, then we're in trouble. And then you're asking favors from other clinicians where
Mhm.
the facility fee is not being met and other things are not being met in the institution. So that could land them into trouble.
Do you think that there's a way do you think we can get to a place where at some point this could be part of that collaboration down the road, that the hope is that maybe we can find a way around some of these barriers so that we can give the patient the best possible or arm them with the best possible team or treatment wherever it comes from?
Yeah, so the Sontag Foundation funded the Brain Tumor Network, which is run by nurse navigation systems that make recommendations for trials. But they don't, they have a few clinicians that they reach out to. And so those clinicians tend to remain within their networks.
Mhm.
And I think a way around it would be if a foundation funded the time of a clinician and covered the insurance so that the clinician would then be a neutral entity,
Mhm.
would be able to navigate the systems. But we don't have that yet.
That's really good information, and it's something that I will keep an eye on so that as things evolve, it's something that hopefully I can let people know that this is something that's hopefully available to people as they continue to go along. Circling back a little bit to IGV, as it gets ready to move into a phase 3, which hopefully won't be too far down the road, I'm assuming you guys will continue to stay on as a PI for that. Can you tell listeners and watchers what being in a phase 3 means? What does that look like? What does that mean?
So, at each stage, and it can get confusing. At phase one, you're looking at safety, and in phase two, you're trying to say, on a smaller scale, is there some signal that it works at the safety dose that we identified? In phase three, you're essentially bigger. So, the we work on phase three studies right now, and there's a push for enrollment. Just the magnitude of the size of the study is different. And you're the step before we go for full approval. There's some post market approval evaluations that happen, but I think there's a sense of a finish line nearby that you feel with it. And I think it also motivates patients as well, that they know that this has been through rounds of testing before, and if it's gotten to this point, meaning that there's something that about it that seems promising. So I think it would be exciting to get there.
So with a phase 3, it's a larger recruitment study, so it's more numbers, more people to bring in. Is it correct to say, and correct me if I'm wrong, but with a phase 3, are there still a control group? Is there still a placebo group, or is that pretty much gone away because they're looking at the efficacy of it actually working in general?
You still oftentimes have a control group in
Okay.
the phase three, so you can study it. But the larger numbers help you to get the statistics right, to be sure that if you do see a signal, that it's true.
Okay.
The
Okay.
What the control group looks like is different between different phase three studies, but it
Different
would,
trials.
yeah, exactly.
Okay. So, my last question to you guys before we round off here, given the intensity of the work that you guys do and the fact that both of you are extremely dedicated to helping patients, and Dr. Sengupta, I know this personally because you have been on my speed dial a few times when I needed to reach out for a patient or a family. And the enormous hearts that you guys have and the passion that you have for doing this kind of work gives me hope in this community. I know Dr. Sengupta knows. I don't know if Dr. Higgins knows, but I lost my own husband to this disease when he was only 45 years old. So I know the ramifications that this disease can have, the impact it can have on a family, on an entire community. So doing the work that you guys do, how do you decompress? How do you de-stress and take away some of the anxiety? Because the stories are not, they're hard stories. And sometimes you don't get the outcomes that you want, or things transpire and things go downhill quicker than you would have liked. And so instead of carrying that home with you all the time, how do you release some of that so you can go back in and do it again?
I'll let you go first.
Okay.
I love how you push that up. Gives him more time to think.
Yeah. So basically, for me, I think having a multifaceted career has been really important, and having a really wonderful spouse and family has been important. So when I say a multifaceted career, I'm not 100% clinical. I do a percentage of clinical. I do research. And that to me, the balance of research and clinical and trials helps me a lot. And the other thing I like doing, which is sort of administration, helping other researchers connect with clinicians and, forming a network so that more ideas come out for the kind of research that can be done for brain tumors is
Mhm.
important. Working with and collaborating with foundations gives me a lot of joy as well. But when I'm out, like for example, this Friday, I'm going out for a week. I always tell my patients, I say, during that week, I'm gone. you know,
You're shutting down. You're shutting down.
Yeah, I mean, if I'm really needed, I'm needed. But I try to make that distinction. And most of my patients and their family members have my cell. So that gives them a sense of comfort knowing that if there's a really bad emergency, they can get a hold of me.
Mhm.
So that I think helps quite a bit. And the other thing is, I work with a phenomenal team. I mean, don't tell Dr. Higgins this, but But my partners in neuro-oncology, and also Dr. Shen in radiation oncology, Dr. Higgins, Dr. David. I mean, the entire neurosurgery team. It's just it really is a great family environment. So if I am shouldering a bad day, I can communicate with one of my colleagues and diffuse the situation. And the integrative oncology that I practice
Mhm.
gives me a lot of joy, because there I can really do virtual group visits with families, the patients, and really address areas because it's all well and good doing trials. But if you don't have those lifestyle tweaks, it's very difficult to stay healthy doing the trials, right? So I think that answers that in a nutshell.
It answers it superbly.
Yeah, it is a lot of stress, but I think we're all, like you mentioned, passionate about what we do and dedicated to what we do. And so, I was. It's not when you hear you have a brain tumor, or if you think something's changing with your brain tumor, it's not something that you want to wait on. And so, I always try to make sure that patients are able to reach me, nights and weekends. And there was one time I was on vacation out of the country, about 10 hours away at a dinner with my wife, and there was an issue. And but it's just something that you have to deal with, and so we kind of sorted it out over the phone. But we have a tremendous team. We work very well together, and I can rely on my neurosurgery partners and my neuro-oncology partners to have this team-based approach, and I think that makes a huge difference. And again, the research. I think if I wasn't doing the work in the lab and trying to develop these clinical trials, I think it's harder to be optimistic about what you're doing day in day out if it's just doing the surgery and then going on. But we do the surgery, we take the tumor out, take it to the lab, we analyze it. We're trying to develop new therapies. Like Dr. Sengupta mentioned, my lab looks at how diet and metabolism can affect tumors, and we're trying to bring those trials to patients. So I think that's a big motivation that kind of keeps you going, despite that the odds are against you. And outside of that, I've become a soccer dad, and that's where I tend to focus my energy. So I'm terrible at soccer, but my son's really good. So
I'm a huge soccer fan, so I like it. And it sounds like both of you have really supportive families and spouses, and that's got to be very grounding for both of you.
Yeah, I've been very lucky that actually my husband and I have been doing brain tumor research together. We
Oh,
share the same
wow.
lab, and so he's gotten to know, when we have brain tumor walks, brain tumor events, he's actively engaged in all of that. And my children have also been involved over the years, and I've also, on the creative side, I've written books in the brain tumor space for children and for adults so that communication barriers come down a little bit. So I think there are a lot of spaces like this that myself and all the team members are able to diffuse.
That's really, it's an important question for me to ask, because when patients and families look at the teams, they look at the surgeries, they look at next steps, they look at what they need to do. They want to know that they're in the best possible hands. And they also understand that this is extremely stressful. And, I've spoken to other neurosurgeons, Dr. Levy, for example, who's a really good friend of mine. And he has said the burnout rate can be really high. You have to be able to balance one aspect with another in order to, you know, keep doing the work that you're doing at such a high intensity and high level. And so I like asking those questions because I hear it over and over again from patients and families. They love hearing this information because it also humanizes you guys. It reminds all of us that you guys are you're human beings like everybody else. You're doing really amazing work, and we need individuals like you doing this kind of work if we want to get to a place where we can treat brain cancer like a chronic disease.
I agree with that, but I think that I would also like to give a huge shout out to patient advocates like yourself, and others that I know
Mhm.
who are a tremendous resource for patients, because I think the pediatricians have it correct. They don't wear a white coat when coming into a room, but a lot of the adult clinicians, we tend to wear it. I think that barrier of the white coat syndrome,
Yes.
and having those patient advocates there makes a huge difference.
Thank you for that. I tend to not know what to say when people give us credit for the work that we do, but we're all in this together, and that's how I see it. Um, we all have to function together, and we all have to do this work together. So, thank you both. To everybody that's watching and listening, I will have all of this information. I'll have links and hyperlinks up on the site. I will make sure to find that children's book that Dr. Sengupta is talking about and make sure we get that up because that's intriguing. So I will make sure all of this is up. It is Brain Cancer Awareness Month. These topics are extremely important. We will have data coming from our partner sponsor, Imvax, as soon as it is available, to showcase the efficacy of their phase 2b trial. And the hope is that we will continue growing stronger together and doing the work that we're doing. It's awareness campaigns and awareness months and all the foundations and the fundraising that goes on that allows you guys and allows me and allows a lot of other people to do the work that we're doing in this area. So I really appreciate all of you, both of you taking your time to sit down with me, to talk to me. I am a huge fan of the work that UNC does at Lindbergh, and the compassion that you show every single person that walks through that door. You are a talented, talented team, talented group of individuals down there, and I am very privileged to know you.
Thank you very
Thank
much
you.
for inviting us.
Yeah, it's a
Thank you
pleasure.
so much. And with that, everybody, we'll be right back. You've been listening to the Game on Glio podcast, the podcast that is designed to educate, advocate, and tell the real stories of those walking the journey of brain cancers such as glioblastoma and grief and loss. Like what you hear? Share us with others. Follow us on Instagram at Game on Glio Podcast, Facebook at Game on Glio, or visit our website or YouTube channel. You can find us anywhere podcasts are played.